Okay, I think we can start because I saw that the number is quite complete, quite large. So good evening to everybody, and good afternoon to our friends across the pond. I am Cosimo Pieri from Europa Uomo Europe, and also part of Europa Uomo Italy. Which are the needs of active surveilled patients during their patient journey? This is the question we want to try to answer today. And with this second webinar and the following one, which we'll have next month, we want to continue to give an information, a basic introduction of active surveillance. And in specific today, we want to focus on overview of the active surveillance patient's journey. You will probably see, obviously, we will see that while the initial phase of decision may be quite complex at various levels and case by case, even progressing in the journey of the active surveillance patient needs some careful management for many things. We think that these webinars are good because we try to increase the communication between patients and association, and between obviously association and patient with the medical community, the specialist community. Having said this, I would like to introduce the first speaker, which is Ioannis Vanezos, which is from Cyprus and is a member of Europa Uomo Europe also in the board and the local Cyprus local association. How are you today, Ioannis?
All right.
All right,
thank
very
you.
Good. So more or less we have tried to consider some questions because to try to be specific. So the questions are more or less which was your experience in the process of choosing active surveillance, which support you got from health services, medical specialists, and what happened during the journey of the decision and during the journey after, and some info about possible side effect like anxiety or something similar. So I leave the speech to you, Ioannis.
All right. Thank you very much, Cosimo. Good afternoon to everybody. And it is my pleasure to be with you and have this opportunity today and share with you my medical journey towards reaching the active surveillance. As Cosimo indicated, my name is Ioannis Vanezos, and I am of Greek Cypriot nationality and right now based in Cyprus. My case or my journey started almost 17 years ago when I was 52 years old. You might be surprised, you might be angry with what you will hear, but this is a real, true life story that happened 17 years ago when in Cyprus, only 7% knew about PSA, and I believe in Europe it was around 10 to 12%. So one day I have been facing terrible urine problems, and I had a very high fever, and I was feeling extremely sick. So I visited a clinic in Nicosia. I was on that time, I was on a trip back to Nicosia because I was traveling in the Middle East. And where after 3 days of a very high and drastic antibiotic treatment with no improvement at all, doctors at that clinic decided that I have prostate cancer and asked me to enter their clinic for further examinations. They were 100% confident that I have prostate cancer and need immediately to be operated as my PSA was 21. They have even asked me to inform my company that I cannot work for about 6 months. You know, today, knowing few things, I'm really surprised with what they have said. Of course, my major problem at that moment was that I had a golden medical card from my company that was provided to me. And it seems that the clinic owners thought they have a chicken with golden eggs. When I was almost entering my clinic room, I have even called my children to notify them about the disaster that I am facing. My wife rejected the idea, started fighting with the present doctors, and requested by force to take me out of the clinic and go for a second opinion. They were almost attacking us at the clinic, but we managed to leave the clinic and go and visit a neurologist in another clinic that he was very specialized neurologist, that he came back from France. He used to be a professor in France. To make the long story short, gentlemen and lady, the result was a urinary infection that with a single tablet, I will never forget it, I cannot mention the name, a very small tablet, for 3 days, I was back to normal without any major problems. Based on this experience, my urologist asked me to check my PSA regularly, and for almost 6-7 years, I had a PSA always at the top of the limit, but at the top of the safe limit, always below the safe line, which means if at the age of X, my maximum was supposed to be 3, I had 2.8. If then it went to 3.5, I had 3.4. So my urologist said to me, Ioannis, don't worry, continue these checks regularly, please. And because I was working with an international company, I was forced to make my normal checkups and analysis almost every 6 months. When my PSA jumped about 10 years ago, my local urologist requested an MRI, and then a biopsy resulted in a Gleason score, which was too low, 2/3. As I was traveling, before this time, before I took any decision, I have checked with specialist urologists in Cyprus, in Egypt, in Dubai, in Bahrain, and then the theater started. Every doctor, depending on his specialty, he was recommending his way of treatment. That, based on my previous experience, I took it very calm, very simple, very, very slow to my decision. And I have decided to go for the proposal that I have got out of one doctor from Dubai and one doctor from Cyprus, that they have suggested active surveillance. Believe me, I was very much confused. But today, when I bring up the story back to my mind, I am laughing and sometimes crying with what has happened. I can tell you honestly, with my hand on my heart, that I wish on that time that I knew the existence of Europa Uomo. I think they were just at the beginning at that time. And to take an opinion on the matter. On that time, Google was not as famous as today. So we were depending on information we were getting from professionals, from people that they have the experience, and even from some patients. Now, you will ask me, Ioannis, what is your, let's say, resume out of your this journey? Awareness and early detection is the pillar to start your journey. And we all know the fantastic work Europa Uomo are doing concerning the above two pillars. That was my basic decision when I went on pension, that I have joined Europa Uomo Cyprus, and then I had the privilege to be also with the Europa Uomo Association in Europe, to be able and to try to help and support other people like myself that I knew nothing, and I was swimming in the middle of the sea without any, I would say, without any official help and support. Being on active surveillance for some years, I think I have only one concern, and this is the very simple expression: when the beast will wake up. My major problem is the psychological stress, and I'm very happy that today we will talk about the psychological stress on when and if and how the beast will wake up. I cannot say for sure, I cannot put my finger and sign today that I have taken the right decision, because between us, we have to admit it, future only will prove. Till now, I have to admit that it's shown that it was a perfect decision. But at least today, I know where I am standing and what I can expect if things go the wrong way. I wish I can get out of my mind this concern, but I can assure you, in spite of normal aging health complications, at least I am enjoying a normal family life. My major headache is the bloody MRI and the agony till the results are written and given to me in my hand to give it to my urologist. And between me and you, whenever I take the results and I read them, I started getting to be an expert on reading the results now. I say to myself, okay, Ioannis, you escaped it once more. Of course, my case was maybe a very easy decision on active surveillance due to the low Gleason score. But we said it was easy because today I know what is the Gleason score. And when I started my journey, I had no idea, the slightest information on prostate cancer or even on PSA treatment. Even on that, I didn't know. So, concluding my presentation, I will say that I am quite satisfied with the decision we took along with my doctors to remain on active surveillance. I am living a normal life, and there is only one question mark: when the beast will wake up. So at least let me enjoy it with this question mark and continue my life and continue to give to my friends, to my colleagues, to my neighbors, to my relatives, all kinds of information that I get out of Europa Uomo, which I thank them that they gave me this opportunity to help people and to awareness of the people about prostate cancer. Thank you very much for your patience.
Thank you very much, Ioannis. And it was very clear. And we will have a question and answer session at the end. So maybe if someone wants to ask something, we can put all the answer at the end. Now, I'm very pleased to introduce to you Professor Riccardo Valdagni. Riccardo Valdagni represents for us a real leader and innovator in the area of prostate cancer and active surveillance in Italy, at least. Since 2003, he has been managing the prostate cancer program in the National Cancer Institute in Milano. And in this period, he has promoted very effective new approaches, like the multidisciplinarity, so from first visit after diagnosis, the support of patients to choose between all the possible ways to strategy of treatment, including obviously active surveillance, psychological support during the journey, and all this based on a very accurate research and organization activities, so on solid ground. He's now director of program prostate program in Cancer Institute in Milano, responsible for the prostate cancer unit and the director of oncologic radiotherapy. So a long experience that could help, may help a lot all of us. How are you, Riccardo, today?
Fine, thanks.
Very good.
I want to thank at first you, Cosimo, and Anva Poppel for kindly inviting me to Europa Uomo. I know very well that I love the Europa Uomo Association, and I talked several times to EAU meeting of Europa Uomo. So I'm really happy to be here with you.
Thank you. So we have a few questions for you. So the first question is this: being presented the option of active surveillance can be initially confusing for the patient. What should a patient know and understand when facing this diagnosis? This is the question.
Okay, essentially based this question on confusion. The answer derived from my experience is that patients should receive clear, unambiguous, balanced information about three critical points. At first, that low-risk prostate adenocarcinoma is not a malignant disease, it's not a beast, as Ioannis said, and that the reason why active surveillance is proposed as an option at the same dignity level of radical prostatectomy and radiotherapy and brachytherapy. The second critical point regards our, and I mean clinicians' language that should be evidence-based, based on national or international guidelines. And the third point is that the decision of active surveillance among the other three treatment options is more complex than the usual decision-making process in medicine. Being, as we know, the three radical therapy equal in terms of oncologic outcome, as we will see, but not for patient risk of side effects. So let's briefly consider the first point. But before supporting the definition of low risk that is not a malignant lesion, I want to underline that adenocarcinoma means cancer, malignant cancer. And this the diagnosis generate patient anxiety and confusion at diagnosis, and confusion in the decision-making phase when we say you have an adenocarcinoma, but is not a cancer, And so you can be followed in active surveillance. But also during the journey of active surveillance, and I mean during the follow-up, patient complain of fear of cancer progression, even if we underline as clinicians that grade grouping 1 or 3+3 Gleason score is not a malignant cancer. So let's see the evidence-based literature, the scientific truth. What they say, that there is a strong biological evidence never disproved. Only one case published in the literature referring to one case of Gleason 3+3 that could have become a malignant cancer, highly criticized by the community. So a strong biological evidence. None of the 6 hallmarks of malignancy are present in the 3+3 or grade 1 cells. And then the clinical evidence, also a strong clinical evidence that is confirmed in the long run. If we consider the figure on the left side, you see results on 5,000 patients, a paper published in European Urology 5 years ago. The prostate cancer mortality registered was less than 1%. And on the right side, you see an unpublished figure of our experience, 1,300 patients followed since 2005 in active surveillance, 100% prostate cancer survival, and no evidence of metastasis, that is 100% of metastasis-free survival for this patient in active surveillance. So very strong evidence-based evidence that low-risk adenocarcinoma is not a malignant lesion. The second critical point, as I mentioned, is it should be evident, but it's not, that the gold for all the community, the gold standard language used by the clinician should always be evidence-based. And as I said, I mean based on scientific truth. A clear example of evidence-based medicine is the declination of this truth in guidelines. The EAU are our referring guidelines in Europe, for US is NCCN. And I want to underline that too many times patients report self-referential languages by our colleagues. And I mean that they say, according to me, to my experience, in my view, not mentioning what the guidelines, the evidence-based guidelines say. And this is one of the barriers. There is a new paper published very recently about barriers to active surveillance. And still talking about barriers and following what Ioannis said about his experience, I want to stress that probably the worst or the strongest barrier to active surveillance is the fact that patient choice can be strongly influenced by the preference of the single physician. Lenny Gomella, a famous US urologist, published in 2011 on European Urology a paper supporting the multidisciplinarity in prostate cancer practice. And he wrote that urologists tend to prescribe surgery and radiation oncologists radiation therapy. Unfortunately, we don't have a specialist in active surveillance. It could be really interesting to have one, but we don't have it. We hope for the future. Cosimo, if you have...
Okay, thank you very much for this. Now, another question is referring to the previous testimonial. Our friend Ioannis said that very simply, every doctor, depending on his specialty, was recommending his solution. So what kind of approach should a doctor have instead of this?
The answer is evident for a clinician who works in a multidisciplinary team in prostate cancer center or in prostate cancer units. The answer is to share the decision-making process with our patients. And the choice should be the result of this shared decision process. Because again, active surveillance is generally proposed as one of the 4 equally effective options for treating or observing low-risk prostate cancer: radical prostatectomy, external radiotherapy, and brachytherapy. So the problem is now how to choose the right option. And let's talk a little bit about decision-making process in general. In medicine, we know that is a linear path. The patient asks clinician, and in general, clinician prescribe the patient with the optimal therapy. In prostate cancer, the scenario is more complex. And I mean that the clinicians having more options to propose, not to prescribe the patient, should suggest the patient the possible therapy or strategies for him. And then, and this is not enough, and then he should explain the treatment-related side effects in terms of quality of events and quantity, and I mean percentage of risk of that specific event. It's clear that we don't have standard reference fixed in terms of percentage of side effects, because this depends on surgeons, on the ability, the history, the culture, the medical culture of clinicians, but at least to give a general weight of the different risks that the patient can suffer, choosing one or the other options. So going a little bit in more detail of the shared decision making process. As I said, it is different in comparison with decision making in medicine. And it's different again because treatment and observational strategies can reach equal oncological outcomes, but they significantly differ in terms of risk and side effects for patients. Using a metaphor, this means that from the same starting point, a low-risk prostate cancer, a grade 1 or 3+3, there are multiple means of transportation: prostatectomy, radiotherapy, for example, active surveillance. This means of transportation means also different travel experiences. The metaphor is of side effects: prostatectomy, urinary incontinence, erectile dysfunction; radiotherapy, rectal or urinary syndrome, erectile dysfunction; active surveillance, the burden or repeat biopsy, anxiety, fear of progression. So that's why the decision-making process in low-risk prostate cancer is more complex than usual. The logical consequence of such complexity is, patient, please ask to be supported, to be the co-leader and not be passive in the doctor-patient relationship. And to be co-leader from the beginning the decision-making phase through all the active surveillance journey. So going a little bit more in detail, what we expect from clinicians, this, I want to underline that this is my personal experience and personal view of the problem. So for me, I think that clinician should properly inform the patient about treatment option and risk benefit of each choice. Is not enough. We should provide him with helpful tools for the decision-making process. And thus, at this point, with a well-informed patient, having him engaged and empowered. That's another critical point, as we will see later. And what I suggest to patients, to take the shared responsibility in the decision-making process, and taking the lead or the co-lead when he personally have to weigh the potential risk of side effects, because this can influence his personal quality of life, and not. And so it's important that we are the judge of our quality of life. This implies, and I conclude this part of the relation with the decision-making, a shared decision-making process. This implies also a radical change in our position, functional position, in the doctor-patient relationship and in clinician and patient attitude, because the doctor, we know, is the subject matter expert of disease. That means he is the technical medical expert who can say, I know as physician what is best for you. But when we talk about choices, about side effects, the subject matter expert on personal values, on quality of life, on deciding which side effects he do not want to undergo is the patient, because he knows what is best for him. Okay. Okay.
Thank you very much. And just to conclude, maybe you can give us an idea how the specialist can support the patient in the decision making. You already told us many things, but maybe you can comment more.
Yeah, trying to be synthetic. I think the message for patients is be an empowered patient. And from a practical point of view, do not delegate your decision to clinicians or relatives, as we as physicians see sometimes, the pressure of the relative to choose one or the other of the option. Very rarely to suggest or promote from the relatives is active surveillance. And I say this because the literature shows us that if the decision is delegated to clinicians or relatives, regret can occur in the long run. Ask clinicians and search for comprehensive, balanced, non-ambiguous information, as we can find many times in the internet, in the web. Information about the care process, the available therapies and active surveillance options, and all the relevant associated benefits and risks. And also ask for and be helped by decision aid tools. We work since the last 12 years with aids on the decision-making phase, and it's really helpful for patients. And provide patients with explicit value clarification exercise to improve informed value-based choices. Be open and prepared to, as we have seen, to reframing doctor-patient responsibilities in the decision-making phase, and specifically the patient should be an actor and non-passive in the decision-making phase. Another important point, if anxiety is a problem for the many reasons that we have seen, ask for psychological or social support. Search for multidisciplinary prostate cancer center or units because it's the optimal way to manage the possible physician bias and minimize regret. And ask to be supported by patient association like Europa Uomo. That is really fundamental. Just opening a parenthesis on the multidisciplinary approach. We, and I know that Ivan Popper is a firm supporter of multidisciplinary approach, is the best setting to empower patients in the decision-making journey. Team members share a common and ambiguous language, the national and international guidelines. All treatment and observational options are proposed in the same clinic at the same time in general. A shared and fairly dialogic context is necessary when there is an unbridged interspecialistic group and not a dyadic asymmetrical relationship between physician and patient. And the patient, lastly, the patient and partner should be one of the specialized member of the multidisciplinary team because he is an active subject of care, specialized in his priority and his quality of life, rather than an organ or a disease to be cured. And what about active surveillance follow-up? Few words, because active surveillance is not a one-shot choice. It rather implies a constant buy-in and a continuous engagement for patients. So what should a patient do in active surveillance follow-up in the journey? Be engaged in the active surveillance process by asking and adopting reliable and easy to use monitoring tools and strategies. Be systemic, that's very important, to follow the planned procedure and referring to biopsy times, visits, PSA tests, MRI tests, and be confident and nurture the therapeutic alliance with your physician. In conclusion, I would say that patients should, again, receive the mantra, clear and ambiguous, well-balanced, evidence-based information on the state and on the nature of their indolent disease, on the available therapeutic and observational options, on existing barriers, specifically the unbalanced treatment prescription that can occur in the daily routine. Information on the unusual shared decision-making process where concluding doctor responsibilities are both technico-medical and supportive of patient quality of life, and the patient's responsibility is to be an actor of his choice, an active subject of care, specialized in his life priority and quality of life, rather than only an organ or a disease to be cured. And I thank you for your attention.
Thank you very much, Riccardo Valdagni. And we are now I have now the opportunity to introduce Lara Bellardita. How are you, Lara?
I'm doing very well, and I'm very pleased to be part of this panel. And so I'd like to thank you for this invitation, Cosimo and Professor Van Poppel and all Europa Uomo. Okay, thank you to you. Now, just to say a few words, Lara is a clinical psychologist and psychotherapist with focus on health, psychology, and behavioral medicine.
A lot of experience has been got by Lara, because she has been collaborating with the prostate cancer unit in Milano, and her focus was on clinical practice, on psychological implication, and specific also on active surveillance. And she has developed a specific interest in healthy lifestyle, being more and more internationally recognized. So now we have a few questions for you, just on these subjects. So specifically, how does active surveillance impact on quality of life from your experience? What are the psychological implications?
We can start by mentioning the functional aspects of quality of life, and we do know, based on literature and based on also my clinical practice, that compared to patients that go that choose active treatment, patients on active surveillance are more likely to maintain health-related quality of life in terms of erectile and urinary functions. But when we talk about health-related quality of life, we're not talking only about functional aspects. We're also, of course, talking about mental health. We're talking about coping strategies. We're talking about post-traumatic growth. So there's the umbrella is very large, and a lot of different factors fall under the umbrella when we talk about quality of life, health-related quality of life. We have no evidence so far, and we've been studying the phenomenon for more than 10 years now, that patients that men on active surveillance show high clinical levels of anxiety and fear of disease progression. So no high clinical levels. That doesn't mean that men do not experience anxiety at all, or that they do not experience fear of progression at all. As Ioannis was very well explaining before, when he was talking about not only his experience, his journey, but his current psychological state. But anxiety, the base of anxiety is fear, and fear is good because it's a primary emotion that is related to survival, that allows us to survive. We need fear, so it's good to have a little bit of fear, because that fear brings us to take things seriously. And being on active surveillance has to be taken seriously. Men have to be compliant in monitoring their disease. They have to be proactively involved in their journey, as Professor Valdagni was saying before. So we shouldn't say that anxiety, a little bit of anxiety in active surveillance is evil. It can be useful. We need to know how to deal with anxiety and somehow monitor the psychological state, just as clinical parameters of prostate cancer are measured and monitored throughout active surveillance. And of course, this is a subjective experience. So it's important that each patient is approached with a personalized intention. So it's important that, as we were saying, as Professor Valdagni was saying before, that multidisciplinary groups provide not only, you know, the unbalanced information, but also the opportunity for psychological aspects to be taken care of. We also know, and that was our particular interest at the beginning when we started conducting research on psychological aspects of active surveillance, that there are protective factors in psychological well-being. And mostly these protective factors have to do with support. Support from spouses, from family members, and from healthcare professionals. So it is important not to travel in the journey by themselves. Relationships are the cornerstone of psychological well-being. And that applies to active surveillance as well. In my experience, as a matter of fact, most of the times that patients requested clinical psychological support, it was because there were divergent opinions regarding active surveillance within the family. And mostly when spouses were not supportive of active surveillance choice. So it is very important that the journey is a family journey from the beginning. The decision-making process has to involve the partner, the spouses, because again, it is something that affects the psychological well-being of the entire family. And those men who have an existing background of clinical anxiety or clinical depression or other psychological conditions should be particularly aware of their starting or of their baseline. That doesn't mean, and I want to be very clear about this, that they should not opt for active surveillance. That's not the case. They should just be particularly aware and particularly engaged in monitoring their psychological state throughout the active surveillance path. So I remember that at the beginning when I was sharing our data and the literature in the medical community regarding the psychological aspects of active surveillance, a lot of clinicians, healthcare professionals were asking me, so we should not propose active surveillance, we should not offer active surveillance to patients who are already impaired from a mental health perspective. And my answer was always no. You need to talk to the patients, and together you need to find the right solution, find the right path. And again, if anxiety becomes a burden that you're not, you cannot carry by yourself, ask for psychological support. Talk to your physician and explain that you'd like to be referred to a psychologist or a psychotherapist.
Good. Now, it was very clear, your presentation. Another subject that we cover sometimes is the lifestyle. So what is the importance of lifestyle for patients in specific with active surveillance?
Active surveillance can be considered in some way in a window of opportunity, because men become patients, but at the same time, they're not sick. And so it's a good time to become proactive in learning about overall health, learning about disease prevention, other diseases prevention. So if you're choosing active surveillance because you want to maintain your health-related quality of life, you should be thinking prospectively and thinking about, well aging, healthy aging. And healthy aging has to do with stress, has to do with sleep, with exercise and diet. All these factors, this is very well known nowadays, impact the body ability to fight illness and promote health. The main underlying mechanism is the decrease of inflammation. So why should men on active surveillance bother about their lifestyle? I remember one patient many years ago saying he was a candidate for active surveillance, and he was saying, that, he wanted to be engaged in the decision-making process. And he was using this metaphor. He was saying, when you take the car to a mechanic, you want to know what's going to happen to your car. You want the mechanic to explain to you what they're going to do, how much it's going to cost. Is the car going to perform better? Not better, the same as before, not the same as before. So following this analogy, following this metaphor, to keep the car performing well, you need to do maintenance, ordinary maintenance and extraordinary maintenance. You need to fill in with the proper fuel. You need to check tires and brakes and substitute and change the tires and brakes when it comes the right moment. So you need to change the tires based on climate and environmental conditions. What I'm saying is, out of the metaphor, our body and mind need to be taken care of by adopting healthy habits and behaviors. And men on active surveillance should really bother about their lifestyle. Also, it's a matter of coherence. Again, if you're choosing active surveillance because you care for your quality of life, do anything that you can do to promote your quality, your life, and your health.
In fact, I think you covered well the point, and you already covered this in a certain way the lifestyle. But coming to diet and active surveillance, it's a part of lifestyle. But do you have some indication to the families to maintain proper eating, what we should pay attention?
Before I talk about diet, let me just briefly mention the importance of exercise. When it comes to healthy behaviors, exercise is the bottom line. Everyone should keep moving, and that particularly applies for men with prostate cancer on active surveillance, and generally for men with prostate cancer. And the indication is exercise as much as you are physically able. So considering your baseline, considering where you're starting from, exercise as much as you can. Walking is a great way to start. And then you maybe can approach other disciplines, other sports, running. You need to engage in activities that increase heartbeat and makes you sweat a little bit. So that's the idea. Sleep is very important too. We don't talk about sleep that much, but it has a very important part in terms of healthy lifestyles. Have your sleeping routine. Go to bed and wake up more or less at the same time. Turn off your mobile phones and tablets at least 2 hours before you go to bed. A lot of times people that have a hard time falling asleep, they think, okay, I'm gonna, check my social accounts and see if I can get sleepy in the meanwhile. Wrong solution, because using our devices wakes us up, wakes the brain up, and that's not what we want at that particular time of the evening. So it's important to keep sleep as part of healthy habits. Psychological well-being, psychological maintenance is very important too. how to stay positive. One very simple and very effective exercise is practicing gratitude. Keep a gratitude journal. For 2 weeks, a month, each evening, write down 3 things that you're particularly grateful for. There's a very strong evidence showing that it decreases stress physiological markers. And it improves our ability to recognize the good things in our lives. And that's very helpful in managing stress and negative emotions. Also, those negative emotions, that anxiety that may stem from, waiting for your test results or when your medical examination is approaching. These kind of practices, these kind of activities lower your physiological arousal and have many benefits in terms of psychological well-being. Make plans, learn something new, learn to play an instrument, engage in those activities that trigger for you positive emotions. Nurture yourself with positive emotions by doing the things that you love, with the people that you love. And it doesn't have to be something big. It doesn't necessarily have to be like your dream vacation. You can practice daily activities that bring a little bit of sense of awe in your life. Dance is a great way of bringing together exercise, music, and relationship with other people. So there's a growing literature showing that dancing improves brain activity and protects against typical impairment related to aging, brain diseases related to aging. So coming to diet now. Right now, one of the most recent and most reliable studies is the meal study that was published last January in JAMA. They wanted to test whether a behavioral intervention promoting vegetable consumption, so bringing men to eat more fibers, more vegetables, will decrease cancer progression in men with early stage prostate cancer on active surveillance. So this is a very specific study. It was a randomized control trial, so it was well designed, of course, with the limitations that all research might have, but it was a very well designed study with almost 500 men who were enrolled in the study and who were casually assigned to 2 different groups, an intervention group and a control group. Those in the intervention group were assigned to a counselor, and they were counseled to eat at least 7 servings a day of fruits and vegetable. The people, the men in the control group were simply given information material and referred to Prostate Cancer Foundation website where they could, read about healthy living, diet, healthy food, and so on and so forth. Well, the findings showed that the men in the control group, in fact, changed their diet, and they increased their intake, the intake of fresh fruit and vegetable servings. Nonetheless, this change in their diet habits did not affect time to progression. So there was no impact on time of disease, of prostate cancer progression itself. But we do know that those changes improve overall health and prevent other diseases, obesity, diabetes, cardiovascular diseases. And we do know that obesity can, in some cases, has been found in some studies related to prostate cancer. So the consequence, the association is not direct, but there's a mechanism that needs to be considered. So a certain type of diet can help overall health. And if you're a man with prostate cancer and active surveillance, you should be bothered by your overall health. There's no evil or good food. Follow the suggestions and directions of World Cancer Research Fund. You have their suggestions on what food you should avoid, what food you should limit. Prostate Cancer Foundation as well has a lot of material. And I think that Europa Uomo, in the Italian chapter, has been working a lot on informing patients on these aspects as well. And I think that Europa Uomo overall in the different local chapters can support men on learning about healthy living. There's a growing interest in caloric restriction. Preclinical studies have been showing that cutting calories down may have an impact on cells functioning. But these studies are still very limited, and there's very, very little evidence in human studies. So we don't really know yet about caloric restriction. So again, no do-it-yourself diet. Talk to your physician. She may be able to provide information directly, or she may refer you to a nutritionist, dietitian. The best scenario will be that counseling on healthy lifestyle is provided within the multidisciplinary team. So with an healthcare professional that is continuously engaged with the work of the multidisciplinary team and is not unaware of the peculiarities of prostate cancer and of active surveillance. So that would be, of course, the best case situation. My main message is healthy living, including healthy diet, is not a destination, it's the journey. And this journey is on a road that has several bumps. Above all, when we face everyday stressors or stress related to prostate cancer, because it's very easy to turn into food in search of comfort, turn into alcohol, turn into smoking in search of comfort. Well, in the short term, immediately you might have, a positive effect. You may feel more relaxed, you may feel happier that you had your favorite cake and your favorite set of burgers. But there's both a short and long-term rebound effect. In the short term, you may feel guilty or unhappy. Unhealthy eating may decrease, may also impair mood. And in the long run, again, unhealthy habits may lead to developing conditions such as obesity, diabetes, cardiovascular disease, which of course do not help when you're already facing, you're in the path of trying to promoting your quality of life and your health. So consider what you eat, so the quality of the food. Consider how much you eat. Quantity matters. consider how you eat. A lot of times we eat mindlessly. We do something else while we're eating. We should be eating mindfully. There's an Italian fictional police detective, Montalbano, created by the pen of Andrea Camilleri. He lives in Sicily. He lives and he works in Sicily, and he does love his food, very much so. And when he's eating, he doesn't want to be talked to by anyone. So what I'm saying is pay full attention to the food you are eating and enjoy it fully. Because if you do so, you'll be more aware of the choices you make it in terms of your diet, and you'll feel when you start to be full, when the sense of satiety emerges, and hence you're more likely to eat better and eat less. And of course, sometimes do indulge in your favorite food. Have your favorite cake, have your favorite dessert, have your favorite burger, have fries. Sometimes do that with family, with friends, out on a trip, sometimes. So give yourself options. The idea here is not to tell yourself, okay, I should not eat this. Give yourself options. Tell yourself, I choose to eat food that I enjoy and that is good for my health.
Thank you very much. So a lot of good advices for our life. And the only thing we hope that we'll be all vaccinated to start dancing, because dancing is at the moment difficult. Okay.
You can start by yourself, so you learn.
Yes, virtual dance. Okay. No, I think it was all very, very clear. I am looking from our secretary if there are questions, but I have already one from the past webinar, which has probably been already answered, but I will propose it. So is a UK patient which is has been active surveyor for 2 years with low grade. So it's no increase in PSA or other symptoms. And his question is why some cancer grow but others don't over several years, and if some cancer cells actually die on their accord without any treatment. It is probably not an easy question, because we probably Riccardo Valdagni already gave some indication about this. I don't know if we can add something briefly or not.
Yes. Can you hear me?
Yes, yes.
Here I am. I mean, to be synthetic, it's the English guy poses many questions in the question, but to be synthetic, again, he talks about why some cancer grow. I mean, because they grow in which way? I mean, they grow locally or they grow locally and metastatize? That's the question. So again, malignant cells grow and metastatize, but we are dealing in active surveillance with grade grouping 1 or Gleason 3+3. Lesions, indolent lesions that are not malignant, they can grow locally. If we look at the active surveillance casuistics worldwide, we see that between 10 and 20% of patients have a nodule, that means a T2 in general, while most of them, 80–90% of patients entering in active surveillance has microscopic disease. But again, if we are talking of low-risk prostate cancer, this can grow locally, and in our experience, out of 5 cases, but not tend to metastatize or cause death of patients. That should be clear. We are talking at 2 different settings. That's the reason why patients and also sometimes general practitioners are really confused about it. I can't hear you.
Cosimo il microfono.
Okay, now I hear you.
Sorry, there are other questions from the audience.
Cosimo, I have one question. I
Yes.
think for Professor Valdagni aussi.
Yes.
Also, does this mean that 3 + 3 will never metastasis? And do 3 + 4 start as 4? Does 3 never involves 4?
Never in medicine is a word to be considered in a difficult way, because the medicine and most of life is based on probabilities. So as I mentioned, there is only one case published in the literature, probably in 2012, if I remember well. This author followed a patient who started with the 3 + 3 and died for metastasis. And they analyzed all the sequence of information, and they thought, they said that everything started from a 3 + 3 lesion. When I talked to one of the most eminent pathologists in the world, he told me, discussing this case, he told me that it was an error in the definition of a small deposit of 3 + 4, and only the 3 component was defined and analyzed by the biopsy. It's the only one. I remember another very important paper published in the US, approximately 15,000 patients with low-risk prostate cancer undergoing radical prostatectomy. If I remember well, there were only 22 deaths among 15,000 people. And when they reanalyzed the biopsy, they found only 19 out of 22. And of these 19 cases, there was a diagnostic error. So we have so many hints in the literature suggesting that 3 + 3 or grade grouping 1 is not a malignant cancer. And if you look at the casuistics in the world, they underline this finding. If I remember well, another incredible number, more than 22,000 people included in active surveillance, including in the Movember GAP3 study, reported 56 deaths. That is absolutely online with diagnostic error at the beginning. 56 out of 22,000.
Very small number.
Okay, Cosimo, can I interrupt? Sorry,
Yes.
we are not meet so many. So the question came from Eric, but Eric had another small comment on that question. So Eric, can you repeat that, what you have sent to me through the chat, please?
Yes, because we always talk about natural history of prostate cancer. And with what we are just saying, that 3+3 is not cancer, I agree we should not treat it as cancer. But this means that the natural history of cancer does not start with a low grade. It just jumps into 4 and then progresses into 5, 6, and metastasis. This seems odd because we all know that even high-grade PIN is a pre-cancerous state, so it's not cancer. It can go on into cancer, and it can, as in other cancers, it might regress and so not continue as high grade. It disappears and it can come back in other cells.
Hi, Eric. Good to see you again.
Hi.
So the first was regarding IPIN. Okay, IPIN, it would be fine to have Ivan Poppel answering to this question because it's his specialty more than mine. But I started studying oncology with the concept of IPIN as a pre-cancer lesions. But since then, I don't want to say how many years ago, the concept has evolved. And when I talk to urologists, they don't consider IPIN in that way in these days. The first question is one of my favorite questions, because I started studying oncology with the concept of upgrading, a progression from 3+3 to 3+4, 4+3, and so on, till to 5+5. So this was one concern when we started active surveillance. And when people ask me about this this concept, I always refer to one study published by the Johns Hopkins group, and they analyzed the essential premise is that we don't have any proof and any scientific proof that a 3+3 can become a 3+4. No way, until to my best knowledge, to follow a 3+4 and really look if these 3+3 changes in time, in the long run. Nonetheless, they used 3 different statistical methods considering the upgrading and the natural history of prostate cancer patient in active surveillance, and using these 3 different statistical systems, they found the same result. And the results are the following, if I remember well. If there is a progression, the risk is between 1 and 2% per year. Okay, so that's what we know in my best knowledge. But we are talking about the risk of a 3+3 to become a cancer. Okay.
Yeah, but
so that's what we know.
So the risk is not evolution of 3+3 cells, but the multiclonality of prostate cancer. Because at the same time, while this one tumor or not tumor plus 3+3 cell group is staying 3+3 in the left bottom, at the right top, there could be creation of a cell group with a 4, who is another clone. It is not.
It's a new prime. It's a new. It's a new cancer, but that's the main understanding at the moment.
But that is important.
There is a progression from the same 3+3 cell. Is very rare.
Okay.
Yep. So we shouldn't biopsy the same lesion because that will stay 3+3.
That's almost impossible if you have microscopic lesions. As I mean, is what I was saying before. 80% of our patients have no visible nodules or clear definition of a microscopic deposit and at MRI.
Mm-hmm.
So
thank you.
Thank
you. I think we covered a lot of aspects, and probably there will be other questions. And
Cosimo?
yes.
Cosimo, can I just leave the question for the American guy? He had a question. Maybe we can finish with his question.
Yes, good idea.
Hey, Steve, can you repeat the question that you have sent to me, please? If he's still here.
Let's see. I'm checking.
Yeah, I'm still here.
Okay.
My voice heard? Can you hear my voice?
Yes.
Yes.
Okay. This is the first time use of audio, so I'm not sure if I had a conversation once through us two, I believe it was, a chat with a emergency room surgeon. He was 70 years of age, and he said he went in after 10 years because of BHP to have the organ removed. And they discovered, despite the fact of being on active surveillance and no reason to do anything after 10 years, they discovered level 4, I believe 4+4. The question really is, the markers we use, Doc, and this is to all of us, the tools we use are not absolute. They give us a good estimation or a good set of input to make a decision as a patient. But we can be harboring a higher grade cancer until we actually open ourselves up. So the question is, if we are told that we're 3+3, and Eric is trying to say this concretely, and I think everyone's hearing the question, if we're trying to judge our life and our decisions as a patient, since we're the final word, on a 3+3 and all the markers that indicate this is the best choice, active surveillance, can we not be harboring a higher grade cancer? In point of fact, have you not found it yourself? And what does that say to an older gentleman that while he may think he's going to live to be 80 years or 85 years of age, may end up being 100 or a lot longer, older. And if he's got a higher grade cancer and it doesn't know it, what does that say to that individual as he ages? What choices should he be making? Is there in fact some, I'm trying to think of the right word, imaging that today shows more promise in telling that older gentleman that he has a higher percentage of choices down one path over another, for instance, surgery? I'll stop there.
Cosimo?
Sí.
You want me to answer?
If it's possible, yes. Maybe.
Okay, just a few words because it's late for me and I have to.
No, in fact, we went over time.
That's a good point at first. When patients exit from active surveillance and go to surgery, what is the situation? Can we find an upgrading? In general, yes, because the upgrading from grade 1 to grade 3 or 4 is the base, should be the base to exit active surveillance. That means that we found somewhere a foci of a lesion not suitable or a grade grouping not suitable for active surveillance. The American guy was talking about a diagnosis at radical prostatectomy, if understood well, of 4+4. Yes, that can happen. In general, from study published in the literature, the frequency of this event is similar in patients not undergoing, not following active surveillance, but starting from a supposed lesion 3+3 or grade grouping 1, they undergo radical prostatectomy. And there are, in general, we can have a percentage of what we call adverse pathology. Adverse pathology variables include 4+4. Does it mean that active surveillance is dangerous for the patient? I mean, and more specifically, the time spent in active surveillance is dangerous. To the best knowledge, we can say no. We have literature and evidence that is not the case. Obviously, as I said before, medicine is probabilistic, and it could be that in some person, time spent in active surveillance can be dangerous. But we don't have proof of this. And we don't have also hints that staying in active surveillance, we can, I mean, we can lose information and not improve the life of our patient. That's what we know. Again, we see sometimes that the patient is totally negative, grade with a biopsy and active survey and MRI, and 1 year left after, very rare patient can develop, and we think from the beginning, a new cancer, very aggressive. But I always say to my colleagues, young colleagues and patients, that there is no one patient follow in an optimal way like person in active surveillance, if they are systematic to PSA test, clinical examination, MRI, and rebiopsy.
Thank you.
Thank you.
Thank you. Thank you very much. I'm sorry that we are going over time, but it was very interesting. We had a lot of inputs, so I want to thank you, Valdagni, Bellardita, and Ioannis, everyone, also for the questions. And we will have another webinar on June 10. Will be Professor Bagma. So I invite you to follow that, and we will go on in case of questions in that time. Thank you very much.
Thank you. Thank you. Bye.
Thank you very
Thank
much.
you. Bye-bye.
Bye bye.
Bye bye.
Bye bye.